Well, hello. It is May the 25th, and it's THCB Gang. I am Matthew Holt, the founder and publisher of the healthcare blog. And damn, it's been a long time since I did one of these. It's mostly been my fault. There's been some personal stuff in the background, some conference travel, and a bunch of getting the gang back together. But the gang is back together. Today, the gang is Jen Goldsack, CEO of the Digital Medicine Society, Mike Magee, I'm a medical historian, and Kim Bellard, regular THCB writer and contributor. And we're going to talk about a lot of stuff that has gone on and going on, and we're going to try not just to talk about AI, even though when we all talk and write about stuff and talk about businesses, AI seems to be on the top of the list for almost everybody. So, hi everyone. I know it's been a while. I would be totally remiss if I didn't not start by mentioning someone who obviously is not here and can't be here, is Casey Quinlan. And for those listening on the podcast and the video, and those of us who either met her or met her via THCB Gang, which I know some of you only met her via the gang, it's a great loss. She died a few weeks back. It was obviously an expected illness. We had her on the gang a few times at the start of this year. And I know we all miss her. Kim, you wrote a really nice, touching piece about her.
As did you.
Yeah, as did I. And as many others, and there's been a lot of sympathy and a lot of the reminiscing and tributes paid on Twitter and across the board. And you know, I think that the one thing that has to be said is that when you get somebody who is as out there and outspoken and loud and energetic as Casey was, and I was on her podcast, Health Critics Hilarious, a couple of times. I presented with her, had her at a couple of conferences. You know, there's always great stuff. I remember one time where we were going to have a small group on stage for the 10th anniversary of Health 2.0 of patients, many wearing the Regina Holiday jackets. We actually had there's actually some photos I put up there of like 30 or 40 people on stage with a Regina Holiday walking gallery jacket on. I remember that we were supposed to like get a group of people, and then some of them were supposed to be ushered off stage. We were supposed to have a smaller group that Lagia Rashadi was going to manage. And basically, Casey went, "No, none of us are leaving. We're all staying here." Lagia ended up having to manage a group of 10. It was a really fantastic, you know, half-hour discussion of patients about you know, about their issues dealing with health technology. And you know, it's good to say, I think, you know, my part is that you really need people who are at the cutting edge, you know, people who are life and death matters to them, to really be telling you what's going on, because a lot of us are sort of, you know, we're around about, we're commentators, we're in the business, but we're not necessarily, you know, dealing with it every day. And it's always great to have, you know, and there aren't that many people who did it with as much panache and, you know, volume as Casey. So we all miss her. So, you know, it impacted me quite a bit more than I thought it was going to. I knew it was coming, but you know, in a lot of discussions when I met people at HIMSS with people about her, and obviously a lot of sort of back and forth between the members of the gang and the wider sort of patient community. So, you know, Casey is gone, but definitely not forgotten. And as you said, Kim, in your piece, you know, she fought some good fights that need to be fought pretty damn well. So, you know, here's to Casey. I only have a glass of water. I don't have a bourbon. I feel out of it. She's the one person who came out to me after a talk I gave and gave me a hit. Said, you know, we were talking about American healthcare and the politics of it. And she said, "You need a shot of this." And she gave me a hip flask. And I took a shot of bourbon. I think it was like 8:45 in the morning.
Well, you know what they say, you can't drink all day unless you start in the morning. That's a great Casey story.
That is, yeah. Yeah, quite wonderful. All right. So I don't know if you know, we can obviously reminisce, and I don't think we'll forget Casey, and we'll talk about obviously in the shows, but you know, some of the topics that she would have been bringing up are definitely things we can come up with this week. So why don't I start going around and just having people either, you know, we can moralize Casey a bit more, or we can or we can dive into you know, what's going on in the last few weeks in healthcare and the wider world. So why don't I start with you, Kim?
Well, I want to do both. I mean, you talked about, we knew the end was coming with Casey, but I was, you know, she was so alive that intellectually I knew the end could be coming, but I really was surprised when she actually died, because she, was such a fighter for so long that the fact that she could actually die was a shock to me. So that's the kind of fighter that she was. And she, all the podcasts we had with her, she never, asked for sympathy or showed any sign of weaknesses. It just, she was so tough. And it just shows everybody's vulnerable, and it's, we're all gonna get it in the end, and how you live it is what matters. In terms of what's going on, earlier this week, the Surgeon General announced that social media is bad for teenagers and young people. And, I heartily applaud that. It's absolutely true. It's having untold impacts. And I'm kind of wondering, I wonder who's going to be the one to break the news to him that we're in a pandemic. There's the news about the social media it's been there for a while. We've known about this. I'm not quite sure why it took this long for him to declare that it's a menace. So I'm glad that he's catching up, but we're belatedly realizing the impacts, and we're going to be suffering the impacts of those for a generation to come at least.
Yeah, I'd agree with that. Also interesting this week, the first part of the US, Montana, bizarrely, trying to ban TikTok, and the addictive qualities of, those of us who are addicted to Twitter and other social media, it's enough of a problem. But the addictive qualities of sort of short form video is something that I think really people haven't taken into account, and also the potential for using the algorithms to direct it, and especially those algorithms are owned or controlled by a company that's controlled by the Chinese Communist Party. Yeah, we have not heard the last of that. For sure.
I honestly don't see how the ban is practically going.
I agree. I understand. Well, India has, you can ban it nationwide.
Nationally,
right?
Yes.
Nationally, and I don't know how you stop it. Probably there are probably things you can do to IP to try to find IPs, but
they're just signal virtuing anyways. They don't really care if it's banned. They just want to make the point.
Absolutely. Jen, what have you been up to? Florida has now announced, your governor has now announced himself to the world, or not, last night, right?
Or not. Hopefully this is just a sign of, that it will be a disaster, but we'll wait and see, and we can only hope, right? I think I do want to take a minute to talk about Casey for a second. Casey was one of the very, very first people to sign up for the DiME Slack. And of course, she then started some very feisty conversations. And, the other thing I will say is she was a supporter of our mission, but also a very good supporter of me from the start. And I think she kind of, figured out quite quickly that I too was not shy about these kinds of things. And, how and when do you sort of use that superpower and when do you not? And she was very, very generous about sharing sort of her knowledge and her experience. And, I think about this is, funnily enough, we're all sort of sharing a sentiment of sort of profound loss for someone who wasn't in our everyday life, but was so important to us because of the sort of shared, vision that we all have for changing the way that we care for people, and how extraordinary she was, and how fun she was to collaborate in all of these sort of initiatives. I think, for me, I've been thinking a lot about how do I think about the courage that she had in the face of her battle with cancer, that unfortunately was far, far too long and far too frequent. But also the voice that she gave and the impact that she had as an advocate, and how can we all sort of channel that going forward. But yeah, she was a tremendous supporter of ours since the start, really important to our community. And I will think often, I think about, look at my what would Casey do bracelet, and try to channel that going forward. And then, Kim, I actually want to pick up on something that you said. It's really interesting, right? The announcement about the harms of social media has only sort of just come out. It was the fall of last year where an ME in the UK actually put onto a death certificate that there was a 14-year-old girl, Molly Russell, and the reason for her suicide, like the cause of death, was social media. And she committed suicide in 2017. So this is not new, but it's taking too long for us to start governing it. Matthew, hopefully something we can come back to that I think is really interesting is the prior auth requirements now around colonoscopies. diagnostic colonoscopies that we've seen coming out of UHC, and then similarly some changes in the breast cancer screening age, which I think is interesting. Interesting to see policies going in different direction, both I think not going to be effective at achieving their goals. So perhaps an interesting one to circle back to.
Yeah, let's come back to that. And great words about Casey. Yeah, I mean, she was a supporter. She was very open, and she also, was always prepared to shout at any time. I remember there was like someone giving a presentation at Health 2.0, and in the 2,000 people in the audience, and I remember someone saying, and I just heard her shouting out something. And
the nice thing was she
yeah.
I appreciated that she was always direct, and she would correct us, and I loved it because it came from a place of, we want you to be better. And it wasn't, I just found it interesting, and there was a sort of genuine passion that she came at everything with. And
it's a great pity. So the Welcome to My Country, Even the Slut book is never going to be written, but it was a great title. It's the title. She said, I'm going to write the book, and the title was out there. But anyway, Mike.
Chiming in with Kim and Jen, for better or for worse, I've seen a lot of death over the decades that I was a physician, and it's not uncommon to be exposed to strong people who do surprising things even when they're under duress. But it's unusual to find someone with Casey's strength who's also funny. Generally, humor and the kind of strength at the end of life doesn't really mix that much. So in many ways, that's to me what made her so unique, was that she almost laughed at death. And she wasn't afraid to touch any subject, in part because she could handle even the worst. So that's what I'll remember, is kind of, she had a kind of impish way about her. It was like a twinkle in the eye. You couldn't really get her all the way down, even though it was obvious the last couple of times we were on together that she was suffering, that she was making the best of it. But still in all, she wasn't willing to give into it, and she was funny besides. So anyhow, she's a unique individual. As far as AI or the Surgeon General's warning, I always come back to the American culture, and the American culture is not real good on restraint. So, maybe we'll be able to come up with some good recommendations. Maybe even we'll be able to put in some regulations that make sense. But in general, Americans continue to do things, even if things that are harmful to them, until they get bored. And when they finally get bored, then they go on to something else. That's what's slowly going to happen with Trump. And that's probably what slowly will happen with at least this particular technology, in part because it'll be replaced by something that is even more sticky than this currently is. So I think what I see when I go around is that parents are now tuned in for certain. And they're doing their own types of regulation as best they can within their home settings to ensure that the next generation isn't harmed by being sucked into this. At the same time, we're a country built on free will, and we certainly seem to applaud youthful self-reliance. There are a lot of kids sitting around with nothing else to do and nobody watching them, who lean into these types of technologies because it keeps them company. So, it was like Matthew put up a piece this week that I wrote because I was concerned that Tom Friedman, when he talked about dual Pandora boxes, one being global warming, the other being AI, that both were opening at the same time. And to some extent, this is necessary because we're going to help solve global warming with AI. And I push back on that because the solution to global warming has very little to do with new technology. We know exactly what has to be done. We don't have the will to do it. So by making believe that you can have scientific fixes to things that are really cultural anomalies, social determinant driven problems of health rather than scientific or technologic, I think is kind of a fool's errand. And that's why I called it out. All that said, as Kim does, I have grandchildren and I watch them and I worry about them. We have 10 of them and they're in 4 different places around the country. And in every case, not only are the parents engaged in these kids' challenges, but more so than we did when we were parents, they're seeking professional help early and often. So, whenever they don't know the answer, they're going to a third party, a psychologist, the schools, or whomever, and seeking out counsel. And we never did that. So to some extent, I think that's a hopeful sign.
Yeah, that's interesting. I mean, Jen has the accent that I have, and certainly when I grew up, the British had the stiff upper lip, and therapy was something that happened in Woody Allen movies only, and now there's a whole range of treatments and issues around mental health and dealing with the head being connected to the body and what can you do about it, and it's come into practice because I think it's come into everyday life, but it's been, people realize that it's there to do with performance as well as illness, and so you see a lot of sports and business use of psychology, meditation, that kind of stuff. So I think it's entered the culture in a it's kind of seeped in over the last couple of decades, especially I think in the US and amongst young people, and being prepared to talk about stuff in a way they weren't before. I wanted to bring in, we've got to talk about healthcare because this is the healthcare blog, THCB gang, but I wanted to bring in 3 other things that that I think were that we've got to mention of sort of in the zeitgeist. One is that today's the 3rd anniversary of the killing of George Floyd, and what happened there and what that awakened amongst the Black Lives Matter movement, but also the sort of response to it, which we were kind of kidding about last night, but the whole anti-woke DeSantis Trump thing is I mean, we're related to that. So that's one thing that's people are mentioning. The second is, you touched on global warming, Mike. I think there was a report out this week that we're now going to cross 1.5 degrees centigrade in warming. We have these grades of how hot is it going to get? Is it 2 centigrades, 3 centigrades? What's that going to do to the world? How much is sea level rise going to increase? Which cities are going to go underwater? How extreme a weather event is going to get. I'm by no means an expert in that. There is some hopeful stuff regarding how fast we are putting in renewable energy. When I say we, I mean the world as a whole. It's growing. That is. I was sitting around going, when is healthcare going to change? The renewable energy sector is definitely changing very, very fast right now. In fact, I literally just went to pick up my kids' pills at a CVS opposite and found that they're digging out the parking lot because they're putting in a bunch of Tesla superchargers. So right in my own little town, where most people seem to have a Tesla and I presumably already have one in their garage. So I don't know if that will be used. But the global warming thing is coming. And then the third thing I've got to mention is that right now, I mean, it's Thursday before Memorial Day, and is it Tuesday or Wednesday? The U.S. government can no longer pay its debts if we don't extend the debt ceiling, and
next Thursday.
Next Thursday, there's political theater about it, which obviously will impact every aspect of the economy, including, of course, healthcare, massively. Social security, and everything else. And I just look at, and as you mentioned, Mike, we have this cultural inability to sort of get past this stuff, even though I see no reason why Biden couldn't just declare the 14th Amendment again, or why Obama could have done the same thing and said, this is ridiculous. We're going to ignore this, ignore this debt ceiling is unconstitutional, and just keep paying our debts, because, it's a bit like, it was a little bit like when they came to rescue Silicon Valley Bank, because otherwise, thousands, if not millions of people might have lost their jobs. At some point you've got to have some faith that the economy can go on in a rational way, and the US government not being able to borrow money when it's made all these commitments to pay our money is really one way. Anyway, so there are three things that are going on that will be in the background, I think, for all the stuff we're talking about. But let's go. Go ahead,
add a fourth. Yesterday was the year anniversary of Uvalde.
To mention really happy things, yes. And it's good to hear we've done so much about it since then. Intractable issues that seem to be, it seems to be that, if that's in the Constitution, allegedly, and the Supreme Court says, that you can do what you like and everyone can own an AR-15 and, with no background checks, and, you can go buy one and a few minutes later be using it on kids in a hospital, wherever. Why we can't say that the 14th Amendment says the US government has to pay its debts with similar absolutism, I don't know. But anyway, yeah, it's very, very, and this, it's a year later, but we've had more mass shootings, in the last few months than we'd had been before that. And again, something we don't seem to be able to deal with. Anyway, I don't have anything good to say about, I don't have anything new to say about it or anything good to say about it, but it's just terrible. All right, now we shut everybody up about all of that. I do want to ask you, especially Kim and Mike, the utilization review thing and the power. Jeff Goldsack had a great piece up on the InVision bankruptcy, which is the biggest healthcare bankruptcy ever, I think, also a very, very large one. And basically looking at the impact of United essentially kicking them out of the network. By the way, this week I got my first ever balanced bill, or surprise bill, which I need to figure out. The claim has been issued and I got sent a check by my insurance company. I didn't actually get the bill from the provider. So it was for radiology when I had the spine injection. Anyway, I will let that develop. But I don't know if this is completely got lost in the memory hole, but I kind of remember I want to say 2001, 2002, sometime after the first sort of big wave of managed care, I'm pretty sure that United said it was going to stop doing utilization review. Am I making that up? I've actually gone look for this online and try to sort of find stuff. I can't find anybody, but maybe I'm completely delusional. But I thought at one point they said, well, this is when the healthcare costs started going back up after the sort of managed care revolution that ran out of steam in 97, 98. And I'm pretty sure at that point, United said, we're doing utilization review and it doesn't make any difference. We're going to stop doing it. Clearly that didn't last. That policy didn't last very long. Anyway, but Jen, do you want to say a bit about what, bring up a bit more about what you're saying regarding, I think it's colonoscopies and breast cancer screening?
Yeah, and it's, we're thinking about this a lot because, and I can't remember if I shared this with this group, but we launched at the end of March CancerX, which is, we are co-hosts of this public-private partnership. It was announced in February on the 1-year anniversary of the Reignited Cancer Moonshot. And the purpose of this public-private partnership is to harness the power of innovation to help achieve the goals of the Cancer Moonshot. So to reduce the number of deaths by cancer in the US by 50% in the next 25 years. So these are big and ambitious goals, and that's why they call it a moonshot. So at DiME, we host that alongside our colleagues at the White House, at Moffitt Cancer Center, and actually at ASCO, which is next weekend now coming up. We've got over 90 organizations to announce as our founding members. So an exceptionally sort of activated and excellent group has come together to really think about how we use innovation here. But it was interesting to see sort of two policies around screening, right? And then we can get to AI and maybe how that can help or not. But UHC announced that they were going to start demanding prior authorization for diagnostic colonoscopies. And you think about the sort of routine screening, they're going to continue to cover. But if someone is actually actively presenting with symptoms, and unfortunately, we know in some communities in particular, it takes a while before you actually go, you take those concerns to a physician, what's the risk of, a delay due to prior authorization that results in, an advancement of a stage of, colorectal cancer that could have been avoided. It just feels like absolutely unconscionable. Similarly, and going in the other direction, they actually changed the guidelines around breast cancer screening for women, bringing the age down from 50 to 40. And the rationale there, which I think is very well intended, is the burden of breast cancer is much higher in Black women in their 40s, and they wanted to start trying to capture that. It's so interesting that the only tool we could think of for the job was a blanket change in the screening guidelines. That actually what who's actually going to, underrepresented communities are still going to have greater challenges to access, even when they are mandated by guidelines. And we're also going to see all of the negatives that come with, and breast cancer screening is very controversial, sort of false positives, anxiety, all of these sorts of things in part of that age group for whom it's not actually clinically necessary. But the only way we could think about reaching out was through a blanket policy, because we can't figure out how to talk about equity not being equal or use precision tools to try and identify individuals at greater risk and do targeted outreach. So it feels like such an interesting moment around screening and these two sort of different policies, one from a private insurer and one from guideline-based care. And you just have to think we've got to be able to do better than this in the digital era.
I have a, Matthew will laugh at this, but I have a more cynical view of generally.
Love to hear that.
So
you were right about insulin, by the way, Kim. I was such an optimist on that. And that one came home to roost, didn't it?
So, correct me if I'm wrong, but the US, I suspect, has higher rates of colonoscopies and mammographies than any other country. And yet our cancer deaths from those things are not any better than other countries. I would question, particularly with colonoscopies, why do we do so many of them, and why do they cost so much, and why are we such an outlier with the rest of the world? So you get to your point about, aren't there better ways to do some of these screenings? We're not getting to the root issue of like, well, when should we be doing these things for which people when? Like the breast cancer thing. Oh, it's a socially good thing. It's mom and apple pie. People should get mammographies. Okay, fine. Well, but maybe not, because a lot of people get false positives, and there's statistics that more harm is done in some age groups than others, and like we're not really addressing like, is this really the best thing to do? Or when should we use it? When should we not? What are other countries doing? We don't ask questions like that. Like more is better is always our answer, and it's not.
There's, if you ever hear her speak, Chadwick Boseman's wife tells sort of his story. And, what would have been really interesting is, his life could have been saved if he'd had screening earlier. But he doesn't fall into any guideline-based care. But if you look at things like family history, he absolutely should have been, so this gets to the point, there must be a better way. Right? If we are concerned about elevated rates of breast cancer in Black women in their 40s, reducing the age of mammograms for all women to 40 is not actually going to solve that problem. And as you said, it comes with additional costs and it comes with additional risk and burden. Similarly, we can do all the guideline-based sort of colonoscopies we like, but we have the ability to do precision medicine like this. Like it is here. There is sufficient data. Why are we not pursuing these pathways? This is the question. And I think, Kim, to your point, this is the interesting part of the conversation.
When a lot of GI docs got their own surgical centers and, they got to keep all the money from surgeries, then I think we knew why people do so many of them, because it goes straight to their bottom line. And, it's hard to get like a clinical evaluation with a GI doc, but if you want to do a procedure, boy, they'll get you in. And that is the problem with US medicine.
So at one point, sorry, go ahead, Mike.
No, that's all right. If you go back to when the National Institutes of Health were set up, they were set up by individual diseases. Those diseases were chosen mainly by a couple of women philanthropists in concert with a couple of high-end academic physicians who then formed a lobbying group and were able to define which diseases were going to be the ones that we were going to focus on. And once we did that, everything went procedural. Now, from my standpoint, if I look at something like colonoscopy, I say that's a good deal, because for the minimum of discomfort involved, and I'm putting aside the money, but just for the minimum of discomfort involved, I get cleared of a disease that is the second leading cancer killer in men for 10 years. And I say to myself, hey, that's a pretty good deal. Now, if I were a woman and I was going through a mammography and it cleared me maybe for a year, maybe I wouldn't consider that as good a deal. But colonoscopy, I'm all right with. All that aside, that's a very different issue than does America feel and behave in a healthy way. Feeling and behaving as a responsible, healthy democracy means that you have to be exposed fairly regularly to small doses of compassion and understanding and partnership. You constantly have to be reassured. You constantly have to have somebody reinforcing intergenerational relationships. You have to have somebody who's pointing you to the community resources available. You have to have somebody who believes that the long-term future is bright. That used to be what we taught doctors and nurses to do. And when they would bitch that it's too hard, or they don't get paid enough, people like me said tough shit, because that's what you signed up for. That's what it means to have made the oath that you made. And when we would tell them tough shit, the vast majority of them said, okay. And they went back to doing what was necessary, even though it was a 24/7 kind of hopeless job. They did it. But as soon as we let them off the hook, and as soon as we began to say, this thing needs to be more systematized, this needs to be more structured, we need to have protocols, we need to make sure you don't make human mistakes. What happened is they said, okay, you want me to be a businessman? I'll be a businessman. So now, fast forward, because this discussion was going on 3 decades ago, fast forward, and what do we have? We have people, first of all, we have primary care in steep collapse. It's failed. And I worked hard with the family practice people, and I believed that maybe we could bump that up and it would be helpful. But it didn't. It failed. And as a result, what we're doing is filling in with nurse practitioners and with physician's assistants and so forth. Fine. But the reality is that what we now use doctors for is it's like teaching to the test. They have to do the things that get reimbursed. Why? Because they all work for corporate entities now, and those corporate entities invested in EMR to get reimbursed. That's why they paid all of that money. They didn't do it for better care. And so what we find is that the doctors are going in, they're not even engaging with the patients. Honest to God, they in an annual examination, they don't even feel a belly anymore. They certainly don't do rectals, and they don't do internal exams either. Okay, what they do is they fill out the form to make sure that they get full Medicare coverage, because if they don't, there's hell to pay from the corporate entity that they work for. So we're out of whack. Yes, there is an issue around preventative tests and procedural medicine and so forth, but in terms of actually creating a healthy population that feels safe and secure and is freed generally of fears and worries that are unfounded, our workforce is disengaged. They're not in that business anymore.
Well, a follow-up on that. I've been disturbed. I think Florida was the last one to pass it. They're passing laws where physicians or other healthcare practitioners don't have to do certain procedures to patients if it violates their personal, religious, or moral beliefs or whatever, abortion being one, for example. And I'm like, I don't think that's what they signed up for. I mean, that's right. Doctors, it doesn't matter what your personal beliefs are. The question is, what's best for the patient and what is the appropriate thing to do? Whether you like it or not should be immaterial, but instead, it's now becoming, well, I don't really want to do that. You know, my church doesn't want me to do that. It's like, you're in the wrong profession.
Right.
I'd add, a couple of tangential things. One is, to narrow this down a bit to what should patients be getting and what should be delivered to them. I think you could argue, but Mike, you've made a very cogent argument for it, that there was a sort of professional tradition of doctors looking out for the whole of the patient and caring about them, and that has gone away over time, whether it's because of corporate medicine, whether it's because of technology, whether it's because it didn't exist as much as you said existed way back then. I don't know, maybe. Certainly we didn't have EMRs, we didn't have data, we didn't track what was going on. But when I started in health service research back in the late 80s, early 90s, the studies we did have about what was going on in the 70s and the 80s weren't beautiful, weren't pretty, right? It wasn't as though everything was perfect and it all fell apart. I think we probably have done more analysis of what wasn't perfect. To flip that around, we do still have, ProPublica came out with, which has been not kind to United Health Group or many other organizations in healthcare, came out with an article just this week about vascular surgery and how certain vascular surgeons have taken advantage of the ability to move it into the outpatient setting and are doing, essentially doing massive overuse at home to patients and making a ton of money out of it. There's one particular vascular surgeon in Maryland who probably has had to, get into his bunker this last couple of weeks because his patients find this. He may never have another patient. But the whole thing about United's argument about utilization management for colonoscopy was that people were doing too much of it. It was being done in unnecessary cases, et cetera, et cetera. We're spending too much money, and we can't afford it. And we don't have a better way of saying, how do we manage the overuse that we know still goes on? So I think that's, although it has to be said, I'm not sure I would be volunteering for a colonoscopy just for pleasure. But anyway,
but their doctor told him.
But having said that, Jen's got a point. Was if we're not going to have sort of professionalism of doctors be the way that everyone gets managed, we have people moving between employers, health plans, doctors all the time, which is why go back to why she wanted access to the data, because the data was spread everywhere. And now the data, we are starting to get our hands on the data. We're starting to get our hands on medical records. We're starting to see the ability via the 21st Century Cures Act and TEFCA and elsewhere and HIPAA of getting electronic access to data. It's slowly starting to happen. My sense is that, you could argue that now with the combination of the data and, for want of a better term, AI, but better analytics and the ability to have, more personalized management by using computing power, we should be able to chart a course. And maybe this is what you guys are doing in CancerX, Jen, of getting us to a place where, it's much more individualized. Instead of being all women under 40, over 40 get this, or under 50. I remember there was a whole bunch of fuss about this in the during the death panel argument that Sarah Palin came up with when the ACA was being passed about, the task force put the recommendation back up to 50 or down to 45, or they changed it anyway, and there was a lot of fuss about that. But it should be that, yes, you are you are this person, this family history, this location, this zip code, this type of whatever, and you should be able to get pinpoint recommendations for you, and someone should be managing the process of that getting to you and actually happening, which is the second part.
Well,
so
I mean,
you fixed this, Jen, have you?
Yeah, exactly. Take out your pencil, I'll tell you. And so here's what I think is interesting. I think this notion of sort of precision prevention, as well as, you know, in addition to sort of precision medicine, and we live in a healthcare system that's reactive and is a sick care system. So I think the notion of precision prevention and the use of all these sort of measures and data and information is really important. But Mike, I want to, if I can, I'm really curious to get your take on this, because the story that you tell, the sort of the case that you made about, you know, what does it mean to be a physician and what are your incentives? You know, we do have greater access to all different sorts of data. We now have this compute power that allows us to do things. Like, Mike, what for you is the greatest opportunity for these, Matthew, I'm going to follow your lead here, for AI, right? Is it the fact that we know that your large language models, right? You know, your ChatGPT is now more empathetic than your clinician, right? Because we've burnt our clinicians out, and because, you know, the anesthesiologist wheeling someone to the cath lab who says, oh, by the way, there's a small chance you might need a blood transfusion, has to explain for the bazillionth time that that doesn't mean that you're getting a COVID vaccine, right? And they're exhausted and they don't want to have the conversation, and they're tired of that conversation. Like, we have done that by the system that we've created. We also have just been talking about precision approaches. Like, if there was one thing we could do with these tools, is it taking out the administrative piece? Is it actually being human, where we have exhausted the humans that we are relying upon that currently? Is it differential diagnosis? It like clinical decision support? Like, I'm super curious, Mike, to hear from you about what gets you excited and what makes you terrified on behalf of the profession and our job to care for people.
Well, you know, it's a great question, Jen. I mean, here's where it kind of begins for me. People can tell you whether or not they're satisfied with their encounter with healthcare. And it sort of begins with, I'm nervous, I've got a problem, I don't feel well, I need to see a doctor, but I can't see the doctor. So the first thing is, they get even more upset because they're not feeling well. They know they need to inconvenience themselves, their family, their job, and get in to see somebody, but they know it's going to be hell to try to get in to see. And oftentimes they end up in urgent care, and that doesn't particularly go well, and it's expensive. So the first problem is the barrier to entry. Exactly how that gets fixed, I'm not entirely sure, but the way the corporate entities that I'm most aware of have handled it is they take all the scheduling out of the point of care, put it in a centralized office with someone who is poorly trained and is using an algorithm and tells you, sure, you can see your doctor. The next appointment available is in 12 weeks when they have an acute problem. Now, that does two things. Number one, it doesn't solve their problem, but also it makes them angry. So already you got an agitated person. So that's the starting point. Now, if you were able to fix that problem and I were able same day to see a human being, what would I want out of that experience? Usually it's not a lot of testing. I want to be reassured that my worst fears, and they usually are magnified times 10 to what they actually have to fear. I want somebody to say to me, you're fine, that lump is normal, or you're fine, I don't see fluid in your ear, or you're fine, that is not a torn cartilage, it's just a strain. I want somebody to reassure me. Now, they may not be perfectly correct. They may not have a lot of scientific evidence to back it up. But you know what? 9 out of 10 times, I'm going to feel much better leaving that office because somebody put some hands on me who's supposed to know what they're doing and reassured me in a way that's skilled because they know how to calm people down. So what I want most of the time is compassion, understanding, and a sense of partnership, that somebody is in it with me. and I want to make a mutual decision. So I want to be able to come to a common agreement with the person who's committed to taking care of me, that this is how we're going to handle this. And I want to know that if need be, I can get back in. So that's the second thing. If I could break through and see a human, I want the person to behave like a human being. And that's more of a social science kind of job. But when we studied this, and we did in 6 countries back in 1999, in every one of the countries, this relationship between a health professional and a patient was changing because the patient was becoming more sophisticated. But they were all going in the same direction. They knew what they wanted. They wanted compassion, understanding, partnership. They wanted physical access. They wanted to be touched. They didn't want a computer. Even though they were certainly willing to accept good data and good science, and that's a great thing. But that's not what they were coming into the office for. They were coming in, believe it or not, to be touched. So if I were building a system, it has to be high touch. Like right now, when my primary care guy, who was great, retired, in part because he was exhausted, rather than wait around for another doctor, I chose to be cared for by a physician's assistant. Why? She was nice. You could talk to her. We reached an agreement. She showed compassion. She touched where it needed to be touched. And I felt better when I left. And when she said, "Now, do you want me to hook you up with one of my doctors?" I said, "No, you're fine. I'll take you." Because she gave me what I needed, So anyway, it's a funny thing. There's and I think we sort of knew this back, at least when my dad had his office attached to the house and he made house calls and all of that. We understood that these were 2 different skill sets. The diagnostic skill set and the ability to do a good exam, yes, that was scientific. But the rest of it was really pastoral. And what I'm noticing is that there is absolutely no focus right now on pastoral, and that's a problem.
So Eric Reinhardt, a physician who teaches at Northwestern, wrote a great op-ed in the New York Times this week about birth control pills being over the counter. And the answer is it definitely, certainly it should be from a medical standpoint. The reason it's controversial is because we keep making physicians do too many things that they don't need to do. And that's partly because the AMA wants it that way. And they're fighting scope creep. I want to quote this. He's saying, we need to stop taking for granted that physicians should be the primary people upon whom we rely for our health. Essential preventive care, such as vaccines, referrals for screening exams, mental health exams, nutrition, exercise, can all be done more effectively by community health workers with basic training. So part of this is we have made the physician the centerpiece of our health system, and they certainly should be the centerpiece of our medical system. But there's a lot of stuff that's health, that's not medical, and we don't have a framework for that at all.
Yeah, I mean, it's back to Shantanu Nundy's book, which I'm forgetting the title of, but I interviewed him. He was on THCB again a couple of times about it, where there was this star, he was doing some research, I think in Malawi, somewhere in Africa, and there's this star community health worker who had, less than high school training, but had some ability to contact with other doctors and was out there and doing incredible work, promoting health in the villages. And we don't have our equivalent of that. And that's kind of, we need to find that level of human empathetic skill and then informate the hell out of that person and give the person and the system support. And, I think, you could argue that we could we're seeing a lot. I mean, we're all deluged in all the things AI is going to do and can do. And now with the large language models, somebody was talking about, Jen, you were talking about having, an anesthesiologist having to tell people explain stuff. I read a thing about an ER doc who is essentially got ChatGPT to write him an explanation for some aspect of what was going on, the unlikelihood of this happening. And he was basically reading that out and then giving that to the nurses and saying, just read, when they ask you about this, just read this. Or basically just give it to the patient. This is, we'll have ChatGPT. And you can see we're not so far from having, really believable artificial people, having this conversation. They're already, you can see these people being delivered over the internet on video, and it's going to come, right? It's going to come. The question I'm missing is there a system? Can we develop some kind of system where we could use this technology to actually get two things? One is, can we get the right level of personalization to the people who need it? So the person who is 35 but maybe at extreme risk of breast cancer, or 25 or whatever, gets there, gets to the front of the queue, and the person, for my, I have a fit test. I have the thing where I poop and scoop it up. I poop and scoop, I guess that's what it is. I've never had a colonoscopy, even though I'm 10 very soon to be 10 years past that 50 guideline, because they say, yeah, you're at low risk, it's showing no need to have one, don't do it. I mean, you've got to have that variation, right? Where some people need it, some people don't need it. Let's focus by getting at the data to figure out who does and who doesn't. So that, that's the first part. The second part, which worries the hell out of me, is the people who, when you talk about, I want someone to be there and say, yeah, it's okay. If you look at, go back to the Caseys of the world, people who have got something, you could say there, it's okay. The reason Casey found out she had a recurrence of the breast cancer was that she had back pain, right? And there's a lot of things that show up in some weird way. And we know that an enormous amount of time and effort of people who have problems, significant health problems, come from lack of diagnosis. We can't figure out what it is. No one got there, they didn't get to the right person to give them the right diagnosis at whatever time. And we do a tremendous problem of wrong diagnosis. I don't know if it's underdiagnosis. Then we have diseases, that we don't understand, like ME or now long COVID or whatever. It strikes me that, we can't just say we're going to have, AI delivered empathy at the right time. We've also got to use these tools to actually improve diagnostics. And I don't know, I suspect that if you actually went through the health service research literature, you'd find out that there is a lot of extra cost and a lot of extra problems caused by wrong diagnosis and wrong types of surgery and that kind of stuff. We could probably, if we could get it right the first time, or get it right closer to the first time, we'd do better. So, like I said, Jen, you've got to solve this in cancer, so it's easy. You have 90 organizations doing it with you. So
I think what's really interesting, and Kim, I think you made the perfect distinction between what's healthcare and what's clinical care, right? And I think that those, we have conflated them through the entire history of sort of healthcare delivery. And I think it serves us to think about them differently. And then, Mike, I think it's you spoke a lot about the training element of this. And I think it's like, we need to make an intentional decision about what we want to use technologies for, and when and why. And then it's not just technology physician. And then what does it mean to be a physician in the digitized era of healthcare? And then who else is part of this industry that ostensibly exists to care for people? And how do we think about using all of them? And how do we layer it and sort of build it in a way that's actually effective at not just treating people once they get sick, but reducing overall sort of disease burden? And, back to, what are we all actually here to pursue? Like, to be able to pursue your purpose, right, in life. And it's interesting to think about how we've embraced as a society, I think globally, sort of mental health care. These transitions are possible. And the question is, what incentives are we creating in medical education, in actually paying for team-based care, which CMS currently does, and in how we are developing and deploying different technologies to reimagine what this healthcare system even looks like. And I think that's the opportunity, but we're going to have to move really quickly, and we're going to have to be incredibly intentional if we're going to harness these technologies and humans to better care for people.
Yeah, Jen, you're right on with that. A lot of this is a training issue. Whenever I talk about this, people think I'm a Pollyanna, and that, I'm talking about something that was so wonderful back when it didn't have any flaws and so forth. And I'm not. I mean, I clearly recognize the role that science and technology have had, and the good that has been done with that. But all that said, part of the reason why the American culture is sick is because the healthcare emphasis is wrong. And part of the way you build a healthy culture, and a culture of democracy, and a culture that doesn't reward extreme greed or avarice or gun-toting, is you create safe, fear-controlled communities. You do that through human contact. Now, hundreds of thousands of times a day, even without really good science, we have been able to stabilize human populations by allowing them contact to professionals who really felt like they had priestly professions, really felt that, this calling that they had was going to make a difference. And it just seems to me that we are not being realistic right now. We're sort of making believe that we can replace this kind of social community with something that's more technologic and not pay a price for that. And I think, we almost need dual pathways. I don't really believe that training physicians to be physician scientists is the way that in general we should be going. I would prefer to see science technologists functioning quite independent of direct hands-on care. I would prefer to see hands-on care being delivered by hands-on doctors, nurses, and others who aren't worried about figuring out how to get a new patent. I don't think it's relevant. I'd like them to take advantage of the patent, and I'd like them to know how to access discoveries, but not at the loss of being a human being. So that's where I come from.
Kim, and then we're going to wrap because we're going quick. As now we're redoing medical education with the new Flexner report, which Mike just delivered.
So sadly, I think the two biggest barriers for AI in healthcare is who's going to get paid and who's going to get sued. If we can answer those questions, not going to happen.
Fair enough. All right. So real quick, we are on our way out here. Look to the future, the next couple of weeks. What are you looking at? What are you looking? What do you think is? What do you got your eye on, Jen?
There's been a lot of conversations on the Hill about how to and whether to regulate AI. I think what I'm hoping to see is some good questions being asked around how we direct it. I think that even just directing and incentivizing can do an awful lot for how these new technologies and tools are developed and used. So hoping to see some of that in the discourse in the coming weeks.
Mike, you've got 30 seconds to give us your next steps, or we've got to run.
Absolutely. I have to run, but I appreciate Jen and Kim weighing in. I do think this is not an easy problem to solve, but I do think it's solvable. And I just don't think it has drawn the type of attention. I think in essence, we need a liberal arts kind of training for our caregivers that parallels the scientific training. And that we may need to separate the streams of physician scientists from the streams of teacher caregiver, and figure out how those things can be bridged without using the same person to do all those jobs.
A very clever eye. Kim?
Well, I'm watching the debt ceiling thing. I want to see how and when it gets solved and how they're going to screw poor people as part of the deal.
Through Medicaid, I know the answer to that one.
You don't worry. You'll all be able to put down, as I say goodbye to the audience. I'll make sure that everyone's able to put down taking part in THCB gang is part of your work requirement. for your government taxes. So feel free to that. So this is Matthew Holt. We're wrapping up the first of sort of the comeback after a bit of a hiatus from THCB gang. Very much enjoyed having my guests on, Jen Goldsack from the increasing hellscape of now banning the poet laureate, or she the young poet laureate, state of Florida, banned by Nazis, when Nazis started now ban books. But there's Jen Goldsack from the Digital Medicine Society, Mike Magee from Connecticut, and Kim Bellard from the frozen tundra, or probably no longer frozen, from Cincinnati, Ohio. And this is Matthew Holt saying thanks a lot. I'll be back on June the 1st with another episode of the THCB gang. Look forward to seeing you all then. There'll be a big one there. I have Ian Morrison, Jeff Goldsmith, Vince Karitis, Robin Van Fanian, and Robin. No, I haven't. Rosemary Day on. So big crowd. So look forward to seeing you then. That'll be in a week. But for now, thanks for listening and watching.